Okay, good afternoon, everyone. We're going to go ahead and get started with today's weekly multi-modality imaging conference. And so following up from last week, this week is also going to be presentations from some of our graduating CV imaging fellows. Our first presenter today is Dr. Purujit Thakur. Puru came to us from Jefferson in Pennsylvania, where he did his internal medicine residency and was also a chief resident. He then went on to St. Luke's Hospital in Bethlehem, Pennsylvania, where he did his cardiology fellowship. Puru's been with us for the last 2 years, training in cardiac MRI, as well as cardiac CT and nuclear cardiology. And he's actually going to take his skills back to St. Luke's in Bethlehem, where he'll become one of the imaging faculty. So Puru, I want to thank you for all your great work you've done for us the last couple of years, and we look forward to hearing your presentation, which is on cardiac PET in the assessment of infection. Puru, thank you.
Hello, everybody. Thank you for that introduction, Dr. Shah. It's a privilege to be here presenting where so many famous people have presented. So I'll do my best to get us through today's topic, which is cardiac PET for the assessment of infection. One of the reasons I picked this topic is because PET is a burgeoning subspecialty of cardiovascular imaging, and as of now, this is one of the less broadly known applications of PET, especially from a cardiologist's perspective. So, as I said, PET imaging has been around for a long time. Being used by oncology. FDG PET has been very well utilized modality for malignancies. And that's because malignant cells take up glucose and have increased utilization of glucose. So similar to malignant cells, inflammatory cells also use up a lot of glucose. And at the sites of infections and inflammation, they do this via transporters called GLUT1 and 3 and hexokinase, amongst many others. And combined PET and CT imaging provides, which is what we do here for our PET imaging. It provides combined morphologic and metabolic information about lesions. So today we're going to talk about F18 FDG PET as a diagnostic tool for infection. The typical applications of this kind of imaging are for prosthetic valve endocarditis, and including septic emboli and extracardiac manifestations. We also use it for native valve endocarditis, which I'll touch upon in a minute. And as you can see here, I have put in some sensitivities and specificities for these, for PET in these applications. If this number seems a little low, it's 61 sensitivity is because a lot of these studies included native valve endocarditis. So we'll talk about that in a minute. It's used for left ventricular assist device infections, cardiac implantable electronic device infections, so that's pacemakers, ICDs, and such. We've actually even used it here for cardiomems devices in the lungs or in the pulmonary vasculature. And vascular graft infections. So we've had a lot of use from our vascular surgery colleagues have been ordering these studies to evaluate for graft infections. The issue with native valve endocarditis, the sensitivity is a little lower for PET, but the reason for that is the pathophysiology of native valve endocarditis. The lesions, the vegetations are usually on the leaflet tips. They're not perfused with blood, and there's no way for inflammatory cells to get there usually. But it is still very specific, if positive. So before we get into, I plan to get into a few cases today, discussing, demonstrating the different applications. But before we get into that, we're going to talk a little bit about how it works. So cardiac cells are very versatile. They're able to use a lot of different fuels, free fatty acids, glucose, lactate, pyruvate, depending on the metabolic circumstances. This is a good thing and a bad thing because from the perspective of imaging, especially PET imaging, this can confound images if you have uptake in the heart that is physiological. So in order to identify pathological uptake, we need to often suppress this, and I'll take you through one of the protocols. But this is just an example, same patient. This was without any suppression. This is just normal physiological myocardial uptake of FDG. And this is the same patient after a prep where there's no uptake now at this point of FDG. So this is the standard protocol. This is pulled from the ASNC guidelines. It begins with a high-fat, low-carb diet followed by a fast. So basically, we advise these patients to eat eggs, meat, butter, everything we normally advise them not to eat is what they're told to eat during this prep. Followed by a fast. This REST MPI is here because this was, this is a combined protocol that's been described for inflammatory and infection imaging. We don't typically do this if we're doing, just infection studies. And then we inject heparin, followed by FDG. The reason we inject heparin is because it increases the serum free fatty acid level, and it causes some lipolysis, and it's been shown to, increase the sensitivity of this test. We have an uptake phase from 60 to 90 minutes. At our institution, we typically keep it around 60 minutes. And then we do the FDG scan. Now, it's, the prep is actually even simpler for cases where we're looking like, for example, LVAD infections or any kind of extra cardiac infection. We don't need to do this prep. This prep is only for prosthetic valve cases or ICD cases where you want to make sure that the heart is suppressed so that you can see the valves clearly, or you can see the pacemaker lead, which is adjacent to the myocardial wall clearly. The standard dose is about 10 millicurie for infections, 8 to 10 for graft infections, and about 5 for inflammatory studies. The reason we use 10 millicurie for cardiac infections is because we're scanning. We usually have a very wide field that we're scanning. We want adequate counts from uptake because we're also looking for extra cardiac findings. And as you'll see through our case examples, that extra cardiac stuff is one of the biggest advantages of using PET in the evaluation of infection. So our first case, very complicated gentleman, 59-year-old man with a history of hypertension and diabetes. He developed severe AI and had a surgical valve replacement in 1985. The details of why he had AI at that time are scant, but nevertheless, he developed prosthesis dysfunction, got another mechanical valve in 2000, then infective endocarditis, and had to have a surgical homograft with a bioprosthetic valve and bypass surgery. Again, developed a bioprosthesis dysfunction and got a TAVR valve. And then another had severe paravalvular leak, presented here with acute AI, and got another second TAVR valve. So this guy has been operated 3 times, and now he has 2 TAVR valves in there. And now, unfortunately, he comes back with fevers, chills, and body aches. And very unfortunately, he was found to have Enterococcus faecalis in his bloodstream. And as usual, as the standard protocol, he underwent TEE and echocardiogram first, and then a TEE to look at the aortic valve. These are a couple of still images of the TEE that he had. I wanted to illustrate here that, especially in somebody who's had this much instrumentation and surgery in the past, it's very difficult to get good echo images. He's got 2, as you can see here, he's got 2 of these evolute valves in here, which are creating a lot of artifact over the valve. It was very difficult on this study to see the valve function, to see if there was any vegetation. So luckily, being at Methodist, we have all the imaging modalities here. And we went on to do a CT, which was a little more informative. There's still artifact from metallic valves in CT, but we can see the motion of the leaflets on a retrospectively gated study. And there was an area, a suspicious area right here on one of the cusps. We couldn't definitively call this, a vegetation or infection. So basically, we were at an impasse at this point, and he ultimately underwent a PET. So this, if you can see, this is a cross-section axial image of the heart. This is where the aortic valve would be. This is the anterior, this is the sternum, and this is the vertebra. So you can see that there was uptake over here, and had a standardized uptake value, or SUV, of 2.2, which in his case was considered significant. But it was quite mild. It was not it didn't look like a raging infection based on the intensity of 2.2. Medical therapy was initiated, and he got IV daptomycin for 8 weeks, followed by, he's still on amoxicillin, and he'll probably be on it for the rest of his life. He's doing well without any symptoms. So he had a repeat PET 2 months later. It came back to us, and we were able to follow up the resolution. So this is the original PET with the uptake around the valve here. And these are two images, two reconstructions of his repeat PET. This is the region of the valve where you can see the inflammation or the infection is completely suppressed. There's no longer any uptake here. And this is the CT attenuation corrected image in color. I wanted to particularly put this image in because there's a little bit of uptake here. This is an artifact that we commonly see. It's brown fat around the heart, which takes up PET. And an experienced PET reader will know that, not to worry about this. But this and the other common artifact we see is, after surgery or any kind of inflammatory process, there is uptake. And there's also uptake when surgeons use adhesive glue, surgical glue. There can be uptake. But this was nothing to worry about. We were overall very happy with how he had progressed. And I think this case illustrates well how PET not only picked up an early case of endocarditis before TE or CT could, but it also prevented this man from having any more surgery or any more invasive procedures done, and it gave us an opportunity to follow up on it.
But how about that uptake in the vertebra?
Yes. So we see a lot of non-specific uptake in the bones, different organs. Usually we have a threshold. A rough guide is the intensity of the liver. If it's more than that, then it's usually considered significant uptake. But also, if it's very homogeneous and smooth uptake, like you see in the vertebra here in the sternum, that's usually something that you're less concerned about. And I'll show you examples later on, in a few minutes about the difference between like smooth or inflammatory uptake or infectious uptake.
But it's gone in the second one.
Sorry. Well, a lot of this is based on how the images are also, you can kind of see it here, but it's based on how the images are leveled as well. So you can kind of see a little bit of uptake in the vertebra here and here as well. Yes.
I'm still not convinced.
It's a great case. But just a comment from a clinical point of view, in the days we had no PET, without PET, probably the CT finding would have been suspicious enough with his previous history that he would have received exactly the same treatment and probably would have done well too. The PET obviously gives us an eye into it and makes us feel more comfortable. But I'm suspicious that without the PET, we would have done very similar things. Because that CT finding was suspicious enough, his history, everything that has happened in the past, I think he probably would have been managed in a very similar way. So,
yeah, that's true.
so the PET just confirms it and makes it a lot easier to do it. But
yes, so that's a good point. You're right. In this case, perhaps he would have been followed up in the same or treated in the same way. But this, as you said, this added a layer of certainty, and it also gave us prognostic information with follow-up. When we saw resolution of the uptake, we now know that treatment is at least somewhat effective. Otherwise, we might have had to wait and see outcomes. And in other cases, it might have pushed us to intervene earlier, do a valve replacement earlier, and such. So, throughout the theme of this talk is that we can do most things here without PET. PET helps us do it better, and it adds a layer of it fits into the clinical and the imaging picture.
on the flip side here, like let's assume that the CT did not show that suspicious lesion. Would you have done, because clearly the PET signal here is not from that mass or whatever it is on the leaflets, right? There's probably some annular
Inflammation
involvement,
around the
right?
annulus, yes.
So I think if there's high clinical suspicion, even if the CT does not show vegetation and with all this hardware not able to see a fluid collection or something, PET would still be valuable if you have high clinical suspicion with
Yeah.
this history.
No, that's an excellent point, and absolutely right. This is not the same case, but here we had uptake all around the annulus, not just at that one point. So a very good point. So just some of the highlights: less hindrance from prosthetic material like echo and CT. It increases the sensitivity of the Duke criteria without decreasing the specificity. And it can help identify extracardiac involvement. So some examples here, this is not from our hospital, but there is septic emboli that seem to have gone to the lumbar spine here, to the chest and the shoulder, the sternoclavicular joint and the shoulder joint. So this is more akin to what Dr. Zogby was alluding to. When we see septic emboli or abnormal uptake, it usually looks like this. So case number 2, this one is pretty dramatic. 79-year-old gentleman, the destination therapy heartmate LVAD3, also came in with Enterococcus faecalis bacteremia. That's kind of a theme in my talk, the Enterococcus. CT chest did not show any definitive findings of infection, and a PET was ordered to evaluate the LVAD and the spine. So he presented with severe back pain, so there was a concern for spinal septic emboli or osteomyelitis. Now, the spine didn't actually show any uptake. Again, this is physiological uptake. This is not infection. It was thought that he injured himself, and that's what the back pain was coming from. But it was a good thing that he came to the hospital because we found that there was extensive uptake in his VAD outflow tract. And this is the drive line. We can see the in situ portion of the drive line has intense FDG uptake as well. And we could also see he had a generator change shortly before this. We can see that there was uptake around the generator pocket as well. This was thought to be inflammatory, not related to the infection, just because it was so recent and because he had no signs of infection around the pocket. I'm going to talk about pocket infections in a minute, but just so you know, this is like the slew of information we can gather from one study. Unfortunately, he was not a candidate for transplant. In another patient, this could have pushed him up on the list, and central VAD infection is very poor prognosis, and this could have pushed him up on the list for transplant. And he was treated with chronic amoxicillin. Unfortunately, this kind of study, this kind of outcome, this kind of infection has very poor prognosis unless intervened upon. So some of the applications for LVAD, LVAD infections are associated with huge healthcare costs and reduced survival. Everything kind of is kind of non-specific when you're looking for a VAD infection. CT is probably the next most useful thing, but there's been studies that have shown, compared PET to CT, small-scale studies, 30 to 40 patients, which have shown that CT often calls these patients normal, and then they're found to have infection on PET. So, and PET also provides prognostic information about these patients. I just want to make sure we're running good on time. Okay. Case 3. So this is our ICD case. Patient presented with Staph aureus bacteremia. He had a gent change. He's had an AICD for many years, but he's had a gent change relatively recently. That's just the generator pocket was opened. And, because of Staph aureus bacteremia, I mean, it's kind of concern just having bacteremia with any hardware is kind of a soft indication for explanting the whole device. But, we wanted to be sure. So he did have a TEE, which did not show any vegetations. And CT did not show any kind of pocket hematoma or fluid collection or anything else. The PET showed extensive uptake in the pocket and the ICD lead. So you can see here, this is focal pocket uptake in one region. as opposed to homogeneous uptake around the whole pocket, as you would see if it was just inflammation. And we can also see here there is uptake in the ICD lead, this is an old lead. He had the ICD placed a long time ago. It was one of those dual coil leads, which has a coil up in the SVC and in the ventricle. And you can see that this is at an area that would be very difficult to see on a TEE. I mean, you can see some part of the SVC on a TEE, but this is pretty high up. And you might not even see any thrombus or vegetation on it, but there was clear uptake over here. And this kind of pushed the case to extract this patient's device. As Dr. Kunones touched upon earlier, that would this have been any different if he didn't have a PET? But I think it gives us a lot of confidence. We're going through a major procedure, an extraction of an old lead and a dual coil lead, which is hard to extract. And now we have evidence that we should be doing that. It kind of skews the risk-benefit ratio to benefit. These are some examples that I wanted to demonstrate to show a very common artifact that we have with PET. We do all our PETs with attenuation correction. That means that we overlaid with the CT, so you can identify where anatomically your uptake is. Metallic devices like a pacemaker or VAD cause a CT artifact called beam hardening. And that beam hardening can sometimes be misinterpreted by the AC software as uptake. So in this case, if you look here, this is a patient with an ICD. It looks like there is uptake around the ICD pocket, but on the non-attenuation correction images, that means that the CT overlay is taken off. You see that there's no uptake. And in this example, you see this intense uptake in the deep pocket, and you see that it is present on the non-attenuation corrected images as well. So this is a real, if you look here, this is real uptake. I'm not going to go through this whole thing, but basically, PET, especially in the European guidelines, is now firmly integrated into the evaluation of device infections. CT, can be useful, but it often presents later in the course of disease once a lot of damage has been done. TEE, as everybody who does TEE over here knows, that you can see a lot of fibrin strands or thrombi on the pacemaker leads after they've been in for a while. Also, TEE cannot look at the extracardiac part of the lead, and it can't look for extracardiac complications. Inflammation from the device implantation resolves 6 to 12 months after the device is implanted. And PET at this time is very sensitive and very specific. Sensitivity and specificity approach 100%. So one question here would be that, so what do we have to wait for everybody to, 6 to 12 weeks to do a PET? And the answer is no, you can do it sooner. You just have to know how to interpret it. As I said, inflammation usually looks homogeneous, whereas infection looks heterogeneous and focal. So an experienced PET reader should be able to differentiate. Okay, we're running low on time here, but I'm almost finished. So this is our last case, 46-year-old female with a history of PAD status post-aortobifemoral bypass in 2022. Presented with 6 months later with discharge from a left groin wound. She had received a lot of antibiotics, both outpatient and then in the hospital, and a CT, showed a fluid collection, but nothing specific. So she underwent a PET, and as you can see that this is the graft, the aortobifemoral graft, and there's extensive uptake throughout the graft. Vascular surgery took her to the OR. They found purulent material on the graft. They ended up explanting and reimplanting a fresh graft. Unfortunately, we didn't find out in this case what the bacteria was because she had been subjected to so many antibiotics, it probably prevented the cultures. Usually, these are Staph aureus, though we have, actually a study here done by Dr. Almala here has shown that there's a wide variety of bacteria. Not all are equally virulent as Staph aureus. And it seems like she had an indolent infection for some time. So busy slide, but I'm just going to touch on a couple of things. It was compared to CT and MRI. CT, as you can see, had a much lower sensitivity, around 67%. MRI was very good, very high specificity. The sensitivity was a little lower, around 70. But also the MRI studies that evaluated this did not have patients with stent grafts, which can cause artifact on MRI and reduce the sensitivity. Tagged WBC scan is also an option because PET is very sensitive and not necessarily doesn't necessarily differentiate infection and inflammation. So you can do a tagged WBC scan, which is less sensitive but very specific. So these are the future. This is the future of PET for cardiovascular infections. Right now, kind of people are making up their own protocols or going by clinical instinct. Standardized protocols, standardized patient prep in the future is going to make a lot of difference. Direct studies comparing PET to other modalities, advanced modalities. Right now, there's a lot of studies comparing PET to echo, but not much in the way of comparison to CT and MRI. That will definitely help, elucidate PET's role in this process. And then bacterial-specific radiotracers, like maltohexose, fluoromaltohexose. When Dr. Dilsizian, former head of ASNC, was here, he discussed the application of some of these newer bacteria-specific tracers for infection. So all of that looks pretty promising. To summarize, I would say that PET is a newer modality. It's still finding its place. Again, in isolation, none of these, the best thing about having a multimodality program is that no modality in isolation always gives the answer. So it significantly increases the sensitivity and specificity of diagnosis in these cases. And it's very sensitive for extra cardiac findings, either the source of infection or the consequence of infection. And the future is going to bring more standardized protocols, newer radio tracers, and better hardware. And we expect that the utility of PET in the future is only going to keep increasing for this indication. Any questions? Yeah. Yes.
Puru, that.
Maybe before you. This is not my question. This is a text from Argentina. Guess who? Right? Dr. Al-Mallah himself.
Oh.
Talking about responding to my question. Said bone uptake is normal, and in particular in the bone marrow, and usually increases with infection. So there is certain threshold, I presume,
Yes.
that you're going to go beyond.
Threshold and
Thank you,
pattern.
Dr. Al-Mallah. From Argentina.
So, quick
Glad he's
question.
watching.
So,
Yeah.
Puru, one, very nice presentation. I think you did a nice balanced job of providing the fact that there's a lot of excitement, but there's more to learn. One question I have for you, you mentioned the surgical glue that leads to uptake. Is that something that's for a certain period of time in the postoperative period, or is this something that just even long-term will lead to uptake?
So in my, that's a great question. So in my limited experience thus far, I've seen it in patients even long after surgery. Maybe we should keep an eye on the YouTube channel in case Dr. Al-Mallah comments. But I've seen it far out. Typically immediately after surgery, we see the inflammation from the surgery itself, which resolves in about 3 months. But the surgical glue can take up, FDG at even much further out.
And do you have any thoughts on why that is something?
To the best of my knowledge, the pathophysiology of that uptake hasn't been completely, figured out yet, elucidated yet. But it's something that we see quite often. We usually go by the pattern and the location of the uptake. Like I said, for surgical glue and stuff like that, it's usually very homogeneous in shape and uptake.
Okay. And I'm going to put Dr. Al-Mallah on the line here because he's doing his ASNC duty as president down in Argentina, but he's tuned in and watching you guys, and he actually wanted to say a couple of words. So I'm going to put him on speakerphone.
Oh, wonderful.
Was, I got you on speakerphone here.
Yeah, hi Dipan and hi everyone. Sorry I couldn't be with you, but for the surgical glue uptake, yeah, we can see it. And the nice thing, because we have a CT, we can localize where the glue is, because the glue is not all through. It's on specific areas, so we can tell exactly where it is and where the uptake is. And for the bone infection, I mean, patients with active infection are known to have bone marrow activation. So that's why all the cells, the white blood cells that are being produced in the bone marrow, they actually, there's increased uptake, which is like more diffuse, not focal. Otherwise, we have to call it like emboli or so. So these are like some nuances that we have to learn as we are reading these scans and getting more information from them.
All right, thank you, Mawaz, for tuning in. We got another question here. I'm going to keep you on the line here, Mawaz.
Just a quick comment. Hello? Just a quick comment. We published in the journal, in the DeBakey journal, there was a case that we had, actually PET was fantastic. It was a
Yeah. Actually, there is a very good study by Dr. Almala and all here, which specifically deals with graft and vascular infections and PET. I've included it in my references, and it's definitely worth checking out.
Yeah, so a couple of things about the case that Dr. Q is referring to. I mean, specifically that case, there was a new septic emboli in the lungs. The patient had a chest CT before, there was nothing there, and then there was a septic emboli there that had the infection. And the other thing also, that study that we did actually, it was in collaboration with vascular surgery. So before they took the patient to the OR, we actually did PET scan, then they went and did like excision and then culture from the site where we saw the infection. And then we blindly interpreted the PET scan, not knowing what the surgical and pathological finding were. And what we found, very high accuracy. There was only one case that had mild uptake, but the patient was on antibiotics for a long time. So that was one of the indications, and we established our thresholds based on that. So now, like on our machine, any threshold above 5, if it is focal, then we are very concerned about infection. Very important also to note that, like the very first case that you showed, Peru, the patient actually, yes, the patient was on long-term antibiotics, I mean, because he had multiple infections and all of that. But he had a PET scan also that was done 6 months before and was completely normal. So that alerted me to call it, because there was a change, even though it was mild, but the patient was on antibiotics. And so when you have somebody on antibiotics, the intensity of the uptake decreases. So that's why we called it. And then when they changed the regimen of the antibiotics, the follow-up scan, as you showed, it completely resolved there. So I think, and because of all the hardware, and I spoke to the ID and the treating physicians, the patient is actually now is going to be on lifelong anti-suppressive therapy for that.
Great. Thank you, Mawaz, for tuning in. And Puru, thank you very much for an outstanding presentation. We're going to move on to the next speaker. And the next speaker is Dr. Mahmoud Al-Rafai, who's also one of our graduating advanced imaging fellows. And Mahmoud did his internal medicine training at the University of Kansas, and then moved to Houston for his cardiology training at Baylor College of Medicine. He's been with us for the last year doing training in cardiac CT, nuclear cardiology, and cardiac PET. And, I pulled up Mahmoud's CV when he applied to us, which is from a couple of years ago. And I was like, man, this guy's got a lot of publications as a fellow. And I said, I need to update the number. So I think his current number is about 175. So he's really a very outstanding researcher as well. And we're very glad that he's going to be joining us as faculty here once he finishes his training. So Mahmoud, we look forward to your presentation as well.
Thank you very much for the kind introduction. It's a privilege to be here in front of you today, sharing some of the knowledge and some of the work that we've been doing here over the past 11 months. It's been a wonderful year working with faculty and staff, and I'm very happy to share some of the work that we've been doing in the lab. So the title of my talk is entitled Diagnostic and Prognostic Challenges in Extensive Coronary Artery Calcium. I think this is something that we commonly encounter, and it can be a little bit of a challenge when interpreting these studies. So I wanted to bring this to the forefront and see what opportunities we have to improve, diagnosing these patients and prognosticating. So this is the outline of my talk. I want to start with a poll. You're in the CT lab, and this is the second study of the day, and you have this open, and you see a lot of calcium in the LAD and RCA. And this is, not something that we see infrequently. It's very common, and it does make us, question how certain we are about diagnosing this patient, whether or not they have obstructive CAD. So that really is the subject of my talk today. Coronary artery calcium, I think this institution is very familiar with. It's a measure of the calcified coronary plaque burden in the coronary arteries, typically scored using the Agatston scoring method, and not only reflects the amount of calcified coronary plaque, but also correlates with total plaque burden, including calcified and non-calcified plaque. And we know that the higher calcium score you have, the higher risk of future events, including CHD and stroke. And I think the guidelines, cholesterol guidelines and prevention guidelines have done a great job of incorporating calcium in their recommendations. We know that patients with a high calcium score, more than 100, are typically recommended for high-intensity statin therapy. So that is great in terms of management. But I want to shift gears a little bit and talk about more diagnosis. So we know if they have high calcium, they're at higher risk of events, but do they have obstructive coronary disease? And so the diagnosis, as you have seen from the slide before, can often be challenging in this group. And future additional testing is often warranted for further assessment. So coronary calcium, especially a lot of coronary calcium, high coronary calcium burden, more than 400, more than 1,000, is challenging because of something called blooming artifact. The blooming artifact is commonly caused by small, highly dense structures like calcified plaque or metallic objects like stent. And basically what that means is that the lumen no longer is very obvious. And so that's typically caused by the high Hounsfield unit of that structure, and because of the use of what we call smoothing kernels that oversaturate the pixel. So all that small calcified plaque that you see typically looks larger than it should, and that's why it's called blooming. It's literally blooming. And so those structures appear larger than their actual size, and this is obviously will lead to a tendency to overestimate stenosis. And so we do have some solutions in our toolbox. We can use sharper kernels. So the smoothing kernels, basically what they do is that they reduce the noise, but at the expense of reducing spatial resolution. Sharper kernels, or the sharp kernels, will do the opposite. They will increase noise, but they will improve lumen visibility so that we can see the lumen a little bit better. Iterative reconstruction has also been proposed as a way to decrease the blooming. Decreasing slice thickness also can improve the spatial resolution so that we can see that lumen a little bit better. And we can use a narrower field of view. And most recently, with the advent of now photon counting CT, which I think this institution will be getting soon, I think will also help alleviate some of that blooming artifact. But even after all that, I think it's still sometimes challenging to really know whether or not there is stenosis. And so other testing besides CT is commonly done. And so just to illustrate again, a lot of calcification here in this LAD and into the diag. And, is there stenosis? Maybe, maybe not, but we want to be a little bit more certain. And so this is something we commonly toss around, sensitivity and specificity. As you know, I'm a numbers guy, so I just want to briefly talk about this because I think I'm going to use it a lot in my presentation. So sensitivity, just thinking about it, basically what you want is to rule out disease, right? So if you test that's highly sensitive, if it's negative, then you can take it to the bank that it's normal. And so you want to minimize the number of false negatives in this case. On the flip side, specificity is ruling in. So if you have a positive test, then you can also take it to the bank that it's positive. So you have the disease. So you minimize the number of false positives. So just remember those terms when we talk about the other imaging modalities that we commonly use. So FFR, invasive FFR, has been very well described in the literature. We know the FAME trials have clearly shown that assessing the hemodynamic significance of a lesion can help with a combined anatomic physiologic assessment as combined to pure luminal stenosis assessment. With recent advances in CT, with multi-detector CT, improved spatial and temporal resolution, we now have the ability to do computational fluid dynamics on CT scans without any extra image acquisition. So these are all existing scans that get sent to a third-party vendor, and they can give us FFR CT. FFR CT has been shown to correlate very well with invasive FFR and has been shown to improve the diagnostic accuracy of CCTA compared to luminal assessment alone. So it's an excellent test and does help us improve our certainty about diagnosis of obstructive disease. But the prognostic value of FFR CT may be affected by the burden of calcified coronary plaque. These are two studies, NXT and FACC studies, where patients underwent coronary CTA with assessment of coronary calcification burden using the Agassiz method, and they were then sent for invasive coronary assessment with FFR. So it's a wealth of data that allows us to do some nice correlation studies. So on the first panel on the left, this is from the NXT trial. The different colors of the columns refer to the quartile of calcium. And I want to bring your attention to the fourth quartile. So this is patient with coronary calcium score of 416 to 3599. So a high burden of calcified coronary plaque. And you can see with the highest quartile, the specificity is about 65%. So again, if a test is not very specific, if it's positive, then is it really disease or is it falsely positive? On the other hand, you can see that the sensitivity goes up. So if it's negative, chances are it's probably negative, but the specificity in this case is not ideal. And this has been corroborated in the other trial, which is the FACC trial, which specifically enrolled patients with a calcium score more than 399. Same thing, they underwent CCTA, and then they were referred for invasive angiography with FFR, and then the gold standard was FFR less than 0.8 to make these calculations. So in this group, the specificity was about 50%. So 50% specificity is a flip of a coin, right? So if I flip a coin, I get maybe yes, maybe no. That's not extremely helpful. So all to show you that the specificity of FFRCT may be affected in those with high calcium burden. Now switching gears to SPECT, I think this institution has a very rich history in SPECT. We love SPECT. I think it's a fantastic test. SPECT, as you know, is all relative perfusion. So basically what it does, it indexes the highest pixel, and everything else is indexed to that hottest pixel. But there have been some studies that have looked at the relationship of calcium score and SPECT. This is one of the earliest and first and most highly cited studies from this institution by Dr. Chang. This was almost 14 years ago. So among those with calcium score more than 400, you can see that the prevalence of abnormal SPECT is about 30%, which means that 70% of those patients have a normal scan, right? Now looking at the incident outcomes in this group, clearly you can see with higher calcium score, the risk of events goes up, and this is whether or not you have a normal or abnormal perfusion. Now clearly if you have an abnormal perfusion and your calcium score is more than 400, your event rate is really high, 6%, and this is annualized per year. But even in the subset with normal perfusion, quote-unquote normal perfusion, it's about 3%, and we commonly quote this in our calcium score reports. It's a 3% risk of having an event in 1 year. And if you compare that to the group with the lowest burden of calcium, 0 to 10, it's still about a 4-fold higher risk. So high calcium, we know, again, has high risk long-term. Multiple studies have shown that. But was there a missed opportunity here that we may have missed some of these tests? In other words, what's the sensitivity and specificity of SPECT in calcium, high calcium score? So this was another study that assessed the sensitivity and specificity of SPECT according to calcium score burden. And the gold standard here was luminal assessment by invasive angiography with a stenosis more than 70%. You can see that the specificity of SPECT is really high, 95%. If you have a high calcium score, more than 400, and a positive SPECT, you can almost be certain that this is obstructive disease. But look at the sensitivity. It's about 40%. So even worse than a flip of a coin. So that tells me that there may be some opportunity to improve risk assessment in these patients, because a low sensitivity, again, means that you may have a lot of false negatives in this group. And when the stakes are high and you have a high calcium score, you want to be certain that a negative test is truly negative and that you're not calling something falsely negative. So very low sensitivity of SPECT when you have a high calcium score. Now moving on to PET, which is something I've been... absolutely, yes, sir.
Go back to that slide. Can you explain the calcium score less than 100, where sensitivity and specificity are much better?
So with calcium score less than 100, so 1 to 99, I mean, it's the sensitivity and specificity, I think, is good using that gold standard. So 80% for both versus the higher calcium score, which had a higher specificity but a lower sensitivity.
I'll tell you what my explanation is, which I think is important, and I hope some of the studies will shed light on it. The higher and higher your calcium score is, particularly if it is diffuse, in most of the coronaries, and you started actually your talk by saying that SPECT is a relative thing. So you could have ischemia that is rather balanced, and you may not see a defect in those very high ones. And that's why in the smaller one, if you see a problem, it's real, most of it, as opposed to masking the balanced ischemia.
It's a great segue to my next point.
Michael, let me just ask you one question here. You know, if you read stats textbooks, they try to tell you that sensitivity and specificity should not be affected by disease prevalence, right?
Correct.
Unlike positive and negative predictive values.
Correct.
But I think what you're showing us on the left-hand side with the differing calcium scores is really variable disease prevalence,
Right.
right? So can you explain to us why you're having alterations in your sensitivity and specificity of a test, which, again, if again, the classic textbook is sensitivity and specificity should not be affected by disease prevalence.
Correct. Yeah, sensitivity and specificity, correct, Dr. Shah, are characteristics of the test itself, and positive and negative predictive value have to do with the disease prevalence. But I think the sensitivity, and specifically the sensitivity of SPECT, I think is affected with high calcium scores due to balance ischemia. I think with the higher calcium score, you tend to have, especially if it's diffusely calcified in all three coronaries, or if you have like a lot of left main calcification, the perfusion will look completely normal, as you know, because it's all relative. So the highest pixel, the hottest pixel is actually a very cold pixel, and everything else relative to that looks normal, quote unquote. So that's why the sensitivity in that case is quite low, because you may be missing a big chunk of those balanced ischemia. But on the other hand, if you do have any kind of perfusion defect in a SPECT with a high calcium score, you can almost be certain that that high calcification burden is actually causing ischemia, and that is obstructive disease too. Did that answer?
Yeah, no, and I think because I think it has to do with the fact that although you read about in textbooks that sensitivity and specificity of a test should not be affected,
Should not.
I think that's not always the case.
Correct.
Right? And I think you highlighted a great example of that.
Correct. Thank you. So moving on to PET. PET has better spatial and contrast resolution. With SPECT we use technetium. With PET we use rubidium, ammonia, FDG. And we know that the energy of those radio tracers is about 511 versus 140 for technetium. So you can imagine 3 times higher energy will give you better spatial resolution, contrast resolution, as opposed to one detector that rotates LAO to RAO. We have a ring of detectors, and positrons. The way they annihilate in the body when they interact with an electron is they do what's called coincidence detection. So you have 2 gamma photons 180 degrees apart. And that ring of detectors can detect by picosecond exactly where that photon is coming from. So that's another reason why it has such improved spatial resolution. All images are acquired in list mode, at least the way we do it here. So that means that we do dynamic, static, and gated acquisition all at the same time. We do everything co-registered with CT, so all those attenuation artifacts that we deal with other imaging modalities are less of an issue with PET. And then most importantly and unique to PET is the ability to quantify myocardial blood flow. And that's really the crux of my presentation. So I want to start with a case. So you have it's an 82-year-old man, diabetes, hypertension, risk factors, and he was referred to us for typical anginal symptoms. So he underwent PET. Now these are the relative perfusion images. You have your short axis, your HLA, VLA. Now, who in the audience would call this, no vessel or maybe one vessel disease? Because you can see there's a small perfusion defect maybe in the apical and mid-inferolateral, right? But I think everything else, like the mid and basal anterior wall, the inferior wall, the apex, I mean, everything looks to be okay. So if I just had that information, based on if this was the only information I had, I would probably call this, one vessel CAD, OM, circumflex territory. So with PET, as I mentioned, we do CT scans, and so we do also calcium score on top. So every patient who doesn't have a prior stent or CABG will have a calcium score done as part of their examination. So this patient had a calcium score of 5,192. So a high calcium burden by all means. Looking at the gated images, the rest EF was 49% and the stress EF was 48%. So typically when we give stressor agents, regadenoson or adenosine, we expect that EF to go at least 5%. And so there was a, almost unchanged EF, if not a slight drop. So not a big change in EF with this patient. I'll finish that case a little bit later, but let me tell you a little bit more about myocardial flow reserve and myocardial blood flow. So as I had mentioned, MFR, myocardial flow reserve, can be assessed accurately and non-invasively using PET. It's a non-invasive marker of coronary microvascular dysfunction, and it's calculated as your stress myocardial blood flow divided by your rest myocardial blood flow. So when you have any kind of stressor, with whether we're giving dobutamine or regadenoson or adenosine, we commonly expect that stress MBF to double. So the MFR more than 2 is commonly quoted to be normal. And on the flip side, MFR less than 2 has been shown in multiple studies to be prognostic of incident events. And the way that myocardial blood flow is calculated from PET images is from dynamic images. So we know when we inject rubidium, that rubidium goes from the blood pool, gets extracted by the myocardium, and gets retained in the myocardium because some of that actually gets washed out to the blood pool again. So ideally what we want is a tracer that has 100% extraction and 0% washout so that it can result in a linear relationship between blood flow and tracer activity. And so the way we estimate blood flow from these dynamic images is that we fit time activity curves to a mathematical model, and basically from that it will just give us a number. It will give us the stress myocardial blood flow, it will give us the rest myocardial blood flow, and then we calculate the ratio of the two, which is the myocardial flow reserve. And so there's a couple of models how we estimate or calculate myocardial blood flow. It's a one or two compartment model versus the retention model. I won't go into too much detail, but suffice it to say that at Houston Methodist, we use the one compartment model. This is a illustration of the different radio tracers that we use and that are available, I should say. So what you want, ideally, what you want is a tracer that tracks one-to-one with blood flow. So that ideal radio tracer is, has a linear relationship between blood flow. And these are the different radio tracers that are available. Of the available radio tracers we have currently on the market or in the research field, 015 Water is the best because it has almost a one-to-one relationship. 015 Water has been validated against microspheres, and then every other radio tracer afterwards, like rubidium ammonia, has been validated against 015 Water. So rubidium has been validated for use for, and has been shown to accurately assess myocardial blood flow. And it has a almost a roll-off phenomenon, though, that you can see with increasing blood flow. It does track linearly up to a point, but then it kind of plateaus. So, but for our intents and purposes, our focus is more on the lower part of the graph here. It still distinguishes low blood flow in that field, but higher, more than 4, commonly will roll off. But it's still very useful. So I'll just skip that slide, just basically to show that relative perfusion, uses the highest pixel and indexes everything to it. But then once you add back the myocardial blood flow in the 17-segment model, you can capture some of that contrast to be able to distinguish high from low blood flow. So this is the case continued. So this patient myocardial flow reserve is 1.45, so that's less than the 2 that we commonly quote. And the patient subsequently was referred to the cath lab. And I hope these images are projecting well, but you can see this patient has CAD, both in the circumflex, LAD, and in the RCA. So he had 3-vessel CAD and was referred for cabbage. So this is another case, 72-year-old female referred for typical anginal symptoms. And you can see that the relative perfusion images are pristine. There's no... yes, good question, Dr. Zoghbi. So I don't know if this is projecting well, but in all three coronary territories, so in the LAD it was 1.5, in the circumflex it was 1.2, and the RCA was 1.3. But globally it was low as well. So second case, again, normal perfusion, calcium score, sky high, 6,500. The EF, it was 52% arrest, mild increase with stress, and then but had a myocardial flow reserve of 1.9. So this is almost normal, low normal. We were pretty certain that this patient does not have obstructive CAD, but for just wanted to be 100% sure, patient was ultimately referred for an invasive angiography, and you can see from these slides, videos that there's some mild luminous stenosis, but nothing really obstructive. So I showed you a couple of cases, and so is this really a just 2 patients we got lucky, but or is there really like a signal here? So so we asked ourselves the question: does MFR risk stratify patients with high calcium score? And here at Methodist, we're very fortunate to have a registry of patients. Every patient who gets PET testing will get enrolled in a registry. All PET scans are clinically indicated, and patients are followed up for incident outcomes. So we have a rich data set of patients with clinical risk factors, PET data, and then incident outcomes. So all patients in our institution are scanned using a digital PET scanner, and they were followed prospectively for incident events, including MI, cabbage, and all-cause mortality. So starting from a data set of about 6,400 patients, we excluded anyone with transplant, valvular disease, anyone with a calcium score less than 400. ultimately the sample size we had was 2,200 patients. This is everyone with a calcium score above 400. So a large enough sample size that we can do some interesting analyses. So we had a population of about 2,200 patients. Those with a score 419 to 999 were about 1,055. And we had 1,191 patients with a calcium score more than 1,000. The prevalence of impaired MFR in this group was 58%. So 58% had an MFR less than 2. And the calcium score group more than 1,000 were more likely to have an impaired MFR. So 63% versus 51%. And this is driven by stress MFR being low. So the two groups had very similar rest MFR, but the rest MBF, but the stress MBF was lower in the calcium score more than 1,000 group. These patients were followed up for a median time of about 12 months, and in that time frame, 251 patients experienced the primary outcome. Most of these were all-cause deaths, as you can see here. I should say a lot were all-cause deaths, but we had a lot of patients who also had like MI and CABG. So this is the two groups that we have, 400 to 999 and more than 1,000. And these are the event rates, cumulative event rates per 1,000 person years. So just convert this to percent. So this would be like 4%, 8%. So you can see that in both groups, more than 1,000 and calcium 400 to 999, the event rates were pretty similar, right? For almost 4.5%. But once you have a MFR less than 2, then look how the risk goes up pretty dramatically. And when we do the same thing, using Kaplan-Meier curves, you can see that the two groups with calcium and MFR more than 2, so preserved MFR, had very similar risk. But once your MFR became less than 2, and especially if your calcium score was more than 1,000, you had a much, much higher risk. And once we do some multivariable adjusted models stratified by calcium score, even in the calcium score more than 1,000, a MFR less than 2 carries an almost 2.7-fold risk of incident events. And this is adjusting for clinical risk factors, ischemia, and low EF. The same signal was seen in the 400 to 999 group, but it was not statistically significant. Now, I want to bring your attention to this ischemia group. So this is patients with ischemia versus without ischemia. So the presence of ischemia is associated with a higher risk. But remember from the earlier slide I showed where you have completely normal perfusion, but the question is there balanced ischemia or not? So what we further did in this analysis, we stratified those patients by ischemia and no ischemia. And so I want to draw your attention to the patient group without ischemia. So in this group, 1,591 patients, a MFR less than 2 is still associated with about 2-fold risk of events. And this, I think, is because you have a quote-unquote normal perfusion, no ischemia, but maybe balanced ischemia that's not really seen. But once you start accounting for myocardial blood flow and flow reserve, you can actually unmask some of that balanced ischemia. So that's, I think, what the power of MFR is in this group. And briefly, we always want to look at the clinical utility of a biomarker. And MFR does improve both risk discrimination and reclassification. So it does have some clinical utility in our practice. So impaired MFR in patients with high burden of calcium does raise a concern for balanced ischemia, which I think should prompt an anatomic assessment for CAD. But on the other hand, preserved MFR may be used as an opportunity to defer maybe invasive angiography and focus on aggressive medical treatment. Some practical considerations. So we see this a lot in our lab where we have calcium score more than 400. And I wanted to share maybe some thoughts or some suggestions about how we think of it in this lab. So if you have a patient with a known high calcium score, more than 400, say they had a formal calcium score assessment. If their calcium score is more than 400, I think probably the next best step would be PET with myocardial blood flow assessment. If their MFR is less than 2, I think this is highly concerning and warrants consideration of invasive angiography. On the other hand, if their MFR is more than 2, I think maybe use as a reason to maybe defer for now invasive angiography, but importantly focus on medical treatment. Now, if we don't know what their calcium score is, you can consider ordering a formal calcium score. You can review prior chest imaging. A lot of our patients, get chest CTs for different reasons, PE, pneumonia. And while the studies are not gated, it does lend itself to at least a qualitative assessment of calcium score. And then every patient who gets CCTA has a planning scan done. So it's usually a lower KV compared to the traditional calcium score, which uses 120 kV. But it does give us a fair idea of how much calcification there is. So once you review all these, if you think they have a high calcium score, I think you can go into this algorithm where you can refer them for PET and do not proceed with CCTA. I think you can stop right there, call their provider and see if they would be amenable to doing a PET scan instead. If their calcium score is less than 400, by all means, do it. CCTA is a great test, and we can certainly look for calcified plaque and non-calcified plaque. So I think it's a good way to at least be able to, do a good test, and more importantly, be certain of the results you're giving the clinician and the patient. So these are just a couple of images that I picked up while I was preparing for this talk. So this is one patient that I was reading their CCTA, and they just happened to have a prior chest CT done for pneumonia. And clearly you can see there's a high, it's ungated, right? But a lot of calcification in all three coronary territories. And this was a patient that the text did and called me about, and I was like, stop, let's maybe not do the CCTA because it has a lot of calcification. So clearly you can see just from the planning scan whether or not they have a high degree of calcified coronary plaque. And then, we have patients who get referred for calcium score. And this patient, just last week, we read their study, and this is 2,113. So I think if you're a clinician and you get a patient with a high calcium score, I think knowing that information is extremely useful because you know that they're high risk. But if you want to be certain whether or not they have obstructive disease or not, I think then probably the next best step would be to refer them for a PET scan and myocardial flow reserve. And so I love this slide from ASNIC where, we want to do right by our patients and, order the right test for the right reason and for the right indication, done the right way. And so this is really the motto of how we practice things here and something that I felt very proud of how we do things. Before I finish, I just wanted to thank a few people. So this is Dr. Ahmed. He was a fellow with Dr. Amallah right from the start. And now he just went to Yale. Super proud of this guy. A lot of the analyses he's helped us with, and he's going to be great. And I think we're going to see him back here hopefully very soon. This is the core of our department, the PET lab and the CT staff. I've had the really privilege of working with these people over the past year, and I've learned so much from them. And the head of our PET department, Dr. Muazzam Mallah, without whom I think, I probably wouldn't be standing here. It's Dr. Mallah has been my mentor and biggest supporter, and I owe him so much. I know he's listening now from Argentina. He texted me right before my talk. So, Dr. Mallah, if I have any tough questions, I'm going to defer to you. And so we'll move on to questions.
Quick question, if I may.
Yes, sir.
In our outpatient practice, the majority of calcium scores are for prevention. So these are asymptomatic
Correct.
patients that we're doing a prevention algorithm. And in the past, or actually not even the past, even recent present, the usual pattern has been over 400, let's do a SPECT.
Correct.
So are you strongly suggesting that we should X the SPECT and go to the PET? That's the first question. It sounds like the answer is yes.
No, I think, but I'll move on to the second question.
The second question is, if you're strongly suggesting that we go straight to PET, which you made a good argument, are most insurance companies accepting that now? Because that's a big one. Right now for
Excellent
pets, we
question.
have to show that they're obese and blah, blah, blah.
Correct.
So if we switch our practice, we're talking about a lot of patients. We all see a lot of prevention patients here with high calcium score. So if we switch them all to PET, will that be a problem with the issue of approval?
Both great questions, Dr. Q. So I'll start with the first one. I want to make clear that, high calcium score, most of the studies have been done in asymptomatic people. That's the way the calcium score was validated. Patients who are asymptomatic get routinely being tested for calcium, and then they follow them up for events. But a lot of the data that I shared, including the one from Dr. Chang here, these were symptomatic patients. So they were referred for SPECT, and they had a calcium score about 2 months apart from the SPECT, so they were able to correlate the two. And so I think if you're having symptoms and you have a high calcium score, I think if there's a high clinical suspicion for obstructive CAD, the better imaging modality I would say would be PET, simply because of that crucial piece, which is the myocardial blood flow. I just worry with the low sensitivity of SPECT that we may be missing out on. 70% of patients have a normal scan, quote-unquote normal scan in patients with high calcium scores. So I worry a lot of these are actually falsely negative. And so that's why I would be a big proponent of PET. Which brings me to my next point that, yes, it's commonly not an easy task to get insurance companies to accept or to reimburse PET. PET is still expensive, and thankfully some insurance companies will reimburse for appropriate indications. Body habit is being one, and with older age. But I think if we want to do the right test by our patient, I think calcium score more than 400 should be an additional indication. And I'm hoping some of the research that we're going to hopefully publish in the next couple of months may make PET an indication, at least for ruling out ischemia in patients who are symptomatic and who have a high clinical suspicion of obstructive disease. So I think I would definitely add that to the indications for PET.
Let me just probe you or push you a little bit further to the question Dr. Quinones asked is, in the asymptomatic patient that you just got a calcium score as a screening test, and it turns out to be elevated, are you now advocating in that patient? Because again, we have to be careful, as you showed us very nicely, that although the sensitivity and specificity of a test you'd expect should not be altered, it can be altered by disease prevalence, right? And for SPECT, you gave us some nice explanations for why that's the case. There may be other explanations that we don't know about. So I guess I'll ask you that question again, is patient you order a calcium test in clinic, asymptomatic, you're just getting a screening calcium, and it comes back at 500. What's your next step?
Statin therapy. That would be my next step. If they're asymptomatic and very clearly have no symptoms, I would stop there, aggressively focus on controlling their risk factors, primarily their cholesterol, statin therapy, high-intensity statin. Consider even adding on non-statin therapy like ezetimibe, PCSK9, if that is also warranted. And also maybe even consider aspirin. One of my former colleagues who was here, Miguel Cainzos was here, had a very nice paper on the utility of aspirin in patients according to calcium burden. And those with a low calcium score tended to have more bleeding than risk reduction. But if your calcium score was more than 100 and certainly more than 400, I think maybe a reason to start aspirin therapy. Because we talk about prevention as primary and secondary, but it's really, I think, a spectrum. There's a primary prevention and a half with a high calcium score. So I think in that group, I would also consider aspirin. But adamantly, I think I would say if no symptoms, I would just focus on aggressive medical treatment and leave it at that. I would not refer for SPECT or PET if I don't have any clinical suspicion.
Asymptomatic patients who may have significant ischemia in the right setting, right, with diabetics and others. So some stress testing would be important, depending on the population.
Correct.
So going back to the point of the threshold, looks like 400 calcium score is a threshold beyond which you may miss ischemia on a stress spec.
Correct.
So this is the threshold. For people who are listening, I think it's important because they may not have PET. And I think the test should be, it's either a PET or a stress function if you're concerned about balance ischemia. Meaning, a stress echocardiogram is not going to be affected by balance ischemia. Actually, it will be more positive if you have balance ischemia in these situations. So a stress function, as opposed to stress perfusion, if the only thing you have is a stress PET procedure.
Correct.
Right?
That would be also another very reasonable alternative. Great point. All right. Thank you so much.
Thank you.